Diptheria. Diphtheria is also known as the strangling angel of children. It was an epidemic wave till 1890s, and the diphtheria was a pandemic in the World War II. There was a gradual decline in the death due to diphtheria by the early 20th century, which was associated with the improving of the living standards. Pathogenesis of diphtheria. The penetration by the Corynebacterium diphtheriae occurs. The local fibrinous inflammation then results. Toxinemia and penetration of the toxin into the tissue may occur, which results in the blocking of ribosome and the cellular necrosis occur. If the cellular necrosis occur in the cardiomyocyte and the conducting system of the heart, it results in the myocarditis. If it involves the myelin layer of the peripheral nerve, it causes the neuritis. If it involves the tubular epithelium of the kidney, it causes nephritis. Clinical features. The primary focus of infection is the tonsil or the pharynx in more than 90% of the cases. The nose and the larynx are the next two most common sites. There is an average incubation period of 2 to 4 days. Primarily, the children younger than 15 years are affected. In case of the primary or tonsillar area, first is sore throat. There is the absence of the systemic complaint. The fever is usually in the lower range around 102 degrees Fahrenheit. The membrane formation begins after 2 to 5 days after incubation period and grows to involve the pharyngeal wall, tonsil, uvula and the soft palate. The membrane may extend to the larynx and trachea, causing airway obstruction and eventually suffocation. The throat and the neck becomes edematous and lymphadenopathy develops. Also, the bull neck appearance is there. The patient throws the head back to relieve the pressure on the throat and the larynx when there is the presence of obstruction. Swallowing may be difficult by unilateral or bilateral paralysis of the muscle of the palate. The relative lack of fever and dysphagia help differentiate diphtheria from exudative pharyngitis due to Streptococcus pyogenes and Epstein-Barr virus. In case of the laryngeal symptoms, the presenting symptoms are similar to laryngotracheobronchitis. There's initial hoarseness which may progress to loss of voice and respiratory tract obstruction. The membrane may be present over the larynx as well. On the nasal part, it usually affects the infants. There is the presence of common viral upper respiratory tract infection with foul nasal odor. Rhinitis with membrane formation might be present. There might be shallow ulceration of the external nares and upper lip, which is the characteristic. On the skin, there is indolent non-progressive infection. The infection is localized to the area of previous mild trauma or bruising. There can be pain, tenderness as well as erythema. The ulceration with sharp defined borders and formation of a brownish grey membrane may be present. The streptococcal or staphylococcal impetigo may be present as well. The extremities are more affected than the trunk or the head. The other sites that are involved are the ear, which causes the otitis externa, eye causes the purulent and ulcerative conjunctivitis, genital tract causes the purulent and ulcerative vulvovaginitis. Complications. Respiratory complications can be there. Additionally, cardiotoxicity typically occurs after 1 to 2 weeks of illness following the improvement in the pharyngeal phase of the disease. It may manifest as follows. It may cause myocarditis. It is seen as many as 60% of the patient, especially if previously unimmunized. It can present acutely with CHF, circulatory collapse, or in more subtle way with progressive dyspnea, diminished heart sound, cardiac dilation, and weakness. There also can be atrioventricular block, ST or T wave changes, and the various dysarrhythmias. They can also result in the endocarditis. Furthermore, neurologic toxicity is proportional to the severity of pharyngeal infection. The deficit may include one of the following. There might be regurgitation of the swallowed fluid due to paralysis of the soft palate and posterior pharyngeal wall. Also, there might be oculomotor and ciliary paralysis accounting for cranial neuropathies. Dysfunction of the facial, pharyngeal or the laryngeal nerves can be there. Additionally, more peripheral neuritis, occasionally glove and stocking neuropathy. Finally, all the nerve damage due to diphtheria eventually resolves. Investigations. The CVC may show moderate leukocytosis. On urine analysis, it may demonstrate the transient proteinuria. The serum troponin I level seem to correlate with the severity of myocarditis. The nasopharyngeal and pharyngeal swab could be sent for the culture. Enriched Loeffler, Hoyle, Mueller or Tinsdale medium can be used. After Corynebacterium diphtheria has been isolated, determine the biotype. Gram stain shows club-shaped, non-encapsulated, non-motile bacilli found in clusters reminiscent of the Chinese characters. Ilex test can be done and chest radiograph and soft tissue neck radiograph can also be obtained. PCR assay allows the detection of the diphtheria toxin gene, that is TOX. Treatment. Specific antitoxin is the mainstay of therapy and should be administered on the basis of clinical diagnosis because it neutralizes the free toxin only. The antitoxin is not recommended for the asymptomatic carriers. In case of the asymptomatic carriers, antimicrobial prophylaxis is administered for 7 to 10 days. The age-appropriate preparation of diphtheria toxin is administered immediately if the patient has not received a booster injection within 1 year. The penicillin G procaine 25,000 to 50,000 unit per kg per day IM divided BID for 14 days could be given. In case of the cutaneous diphtheria, 7 to 10 day regimen has been given. Also, erythromycin 40 to 50 mg per day could be given. Thank you. Please do like, subscribe my channel and share this video.